Good morning, Dhiren boss.
Please start, sir.
Can I start?
Yes, sir.
Hello, good morning, friends. And greeting from IIP Delhi. On behalf of IIP Delhi, very warm welcome to our all participants. My team of the IIP Delhi, including our president, Dr. Pankaj, or president-elect, Dr. Ajay, my treasurer, Dr. Dinesh Goyal, and other my all executive board members. On behalf of that, I would like to warm welcome our today's session chairperson, Dr. Dhiren Gupta, and Dr. Sonu Udani ma'am, as well as our today's speaker, Professor Dr. Arun Bansal sir. And definitely, IIP Delhi, in continuation of the previous series of the e-master classes, we are trying to deliver the quality of lectures by our very well-known faculties. And I would like to great thanks to my colleagues, Dr. Maninder, to make the lot of the hard work behind the success of this e-master classes. So I would like to invite my president to do the for the welcome words and start the sessions.
Good morning, everybody. I'm Dr. Pankaj Garg, President of IP Delhi for the current year. And all of us are pediatricians, and we look after babies and newborns as well as group have a little higher chance of getting in a shorter period. So we may not be doing pediatric intensive wrong. And if it goes wrong, what can be done immediately to save the life of that baby? So with that mindset, we sat together at IEP Delhi and we decided that we should have a program which is meant for office-based pediatricians and students and every pediatrician for that matter, so that they understand the nuances of pediatric intensive care. We understand that this course is not made to make you a pediatric intensivist, but this is made to make you understand what intensivists do and what can go wrong in a child, so that you can understand the physiology early, you can pick up the illnesses early, you can manage it better, and you are able to understand also what is being done in the four walls of pediatric ICU. With that mindset, we gave this responsibility to Dr. Maninder. Dr. Maninder is our colleague at IIP Delhi, is the executive board member, and also holding a very prestigious post at Amrita Hospital. He's a intensivist at alma mater of Gangaram Hospital. He's a great person, and he's done a really hard work, very good job of selecting these 12 sessions. I can see all the topics are being covered, and the faculty is international standard. You can see that all the sessions are being taken by very senior and very expert people. So with these words, I'll welcome you all. I'll thank my IEP team. I thank Dr. Maninder and all the faculties of this session, Dr. Dhiren, Dr. Sanudani, Dr. Arun Bansal sir, and all the faculties who will be joining in other sessions also for this fruitful discussion. The benefit of this program is that you can have a live discussion, and then after some time, we'll post it also on IEP YouTube channel so that you can see it again. So with these words, I welcome you again, and I to say a few words before we start today's proceeding. Over to Dr. Maninder.
Dr. Ajay.
Yeah, Dr. Maninder.
I request Dr. Maninder to please.
उसके बाद फिर डॉक्टर जी को. हाँ जी.
Good morning, everyone. It's a pleasure and actually an honor to be here and given a chance to the intensive care chapter to present and make this module. So, without further delay, I would, before I begin the course, I would like to thank Arun Bansal sir, who is the current president of our society, to have taken the pain also in deciding the topics and coming out with the module. And sir, it is an honor to have you here. So, with that, I would now introduce the moderators first, and I would request Dhiren sir to introduce our speaker. So the first moderator is Dr. Sonu Udani madam. She is the medical director of SRCC Hospital in Mumbai. Madam has been the teachers of teachers. She actually started the pediatric intensive care chapter of India. Ma'am was my examiner also, and with her blessings, the intensive care chapter have done really gone beyond heights. So we are one of the most progressive chapters with a lot of technology skills coming in. Uh, Madam presently is looking after not only ICU, but the whole of the hospital at SRCC Mumbai. It's a pleasure and honor to have you here, ma'am, with us. And then my guru, my teacher, Dhiren sir, he is my mentor, my guide. He has taught me everything in pediatric intensive care and also in life. So, sir is the co-director at Gangaram PICU, Ped Allergy, and Pediatric Respiratory Medicine. There are no words that can describe Dhiren sir, but I'll just say he's like the Krishna Bhagwan of ICU chapter, if I may. And now I request Dhiren sir to please introduce Arun Bansal sir.
Thank you, Maninder, for such a nice word in the Sunday morning, and that made my day. And we learn a lot of things from each other. And now you're my teacher. Now, to start with the today's session, first of all, about Dr. Arun Bansal, I mean to say he's one of my bestest friend. For so many years, I don't count those years. And what I can say about Dr. Arun Bansal, he is not only a nice, a academician, but a very nice human being and a dear friend of mine. If I look at his CV, it might take around 10 minutes, 15 minutes to partially cover that CV. But I can say that he has mentored lot of MD, DM students. He's a professor at PGI Chandigarh, and he's president, and he has worked as, we both have worked as a secretary and president in 2021-22. And what I can say about other than his academic activity like FCCM in 2018, FRCPH in 2019, and more than 200 paper and more than 50, but he has got an innovative style. And he knows the pulse of the teachers and the students. That's the best thing. Despite in government sector, he knows that what is the requirement of a pediatrician who works in private intensive care as a private pediatrician and in a government setup. And now, so I welcome Arun to this session. And about this topic, I've been in intensive care since 1997 in Gangaram Hospital, and Dr. Sonu is like my mentor to me, and she has taught me a lot other than just intensive care. Now, regarding this topic, and I think Sonu ma'am will agree with me that most of the patient doesn't crash like anything. Something must have been missed by our people. Means we consider ourselves as a pediatrician, pediatric intensivist, and a general physician also. So those missing points are most important. It's very easy to manage at tertiary level once patient is in ICU. The most difficult part is when they come to your clinic, when they come to your nursing home, when they come in emergency. So that is a fault. There's a major fault can happen at that time. So I hope that Dr. Arun Bansal is going to cover those points which a pediatrician requires to cover and to prevent the catastrophe also. So management of catastrophe as well as early recognition of catastrophe is equally important. So Dr. Arun, and it's all your stage. Anything else, Dr. Maninder? You can go ahead.
I think we can request Dr. Ajay Gupta, our president-elect, to say a few words, and then over to Dr. Arun.
Thank you,
Dr.
Dr.
Ajay.
Pankaj. IP Delhi has been at the forefront of all academic activities, dealing with all the topics which are of day-to-day practice importance. And now in the intensive care also, without wasting much time, I request Dr. Arun Bansal to please start the presentation. Thank you.
Thank you, everybody. Good morning. Good morning, IAP Delhi, for organizing such a nice and wonderful initiative. I think the brainchild of all of you will benefit many. And I would also like to congratulate not only for starting this course, but also for getting his first oration. So I got my first oration at the age of 50. He got it at the age of 25. So we all know how academically oriented he is and how much overzealous and how much time and effort he has put in for the IAP and for intensive care chapter. And
Thank you.
moving towards the topic, so in the next half an hour, we will be discussing about this crashing child, the rapid recognition and stabilization. So this is for any pediatrician, and especially an emergency pediatrician or an intensivist, can be a nightmare sometimes, because it can lead to lot of problems. It can lead to lot of complications, and if not attended properly, it can lead to lot of mortality and morbidity. So in this talk, I would like to focus on how to classify the sick children when they arrive in your office practice or in emergency room, based on the severity of physiological parameters, and then how to stabilize this child based on the ABCD approach before we move on to any diagnostic investigations. So I think my main focus would be on the approach, which was very simple and practical and can be followed by anybody. Like Dr. Pankaj said, by general pediatricians, so that can be followed by anybody. I will not talk in this lecture of any specific diseases or any problems. So this is just a broad approach to a crashing child. So what do we mean by a crashing child? So it is basically an imminent or ongoing cardiorespiratory failure leading to potential collapse, and that child requires immediate recognition and stabilization to prevent arrest or irreversible organ injury. So you can come with any etiology, but ultimately it falls down onto the cardiorespiratory failure. So this is where we have to act and identify it early. So it can be a severe respiratory distress or impending respiratory failure. It can be decompensated shock. It could be altered mental status, and finally leading on into cardiac arrest. So in essence, it's a critically unstable child. So in which every minute counts. So here you can't delay. We can't wait for anything. So you need to follow a rapid recognition and structured approach. That is the ABCD approach and the PALS, which we almost all of us must have gone through the PALS courses. And that can make a lot of difference between the survival and the death. If we see what kind of problems we commonly see in the emergency in resuscitation room, this is an American study on a data from 2018. So we see the males predominate, and we see less than 5-year-old are the most common who present with these problems. So they are the main ones who are involved in this, who come crashing to the emergency. And they usually then need to be transferred to different areas of the hospital. And the common problems are neurological problems, respiratory problems, cardiac problem, or drowning. This is the data from our emergency in which we analyzed the data from 9,000 plus patients, and we found that the respiratory, GI, CNS were the most common problems which came to our emergency. And we found that and how did they got disposed within 24 hours? Majority got shifted to ward, and around 200 patients were shifted to PICU, and around 200 died also in here. And that cause of death was mainly sepsis, HI, CNS, or CVS causes. I think this is the PICU and the patient who died are the one where we need to focus more, because they are probably more critical. So what are the pathway which we need to follow? So we don't need to do too much. We just need to follow some physiological impairments and classify into or any etiology. Like it can be because of infections, it can be trauma, it could be toxins, it could be congenital metabolic, or it could be cardiac. Ultimately, they all lead to physiological impairment. And this is where we need to recognize that whether it is respiratory impairment, circulatory impairment, or neurological impairment, leading to cardiopulmonary failure and subsequently to cardiac arrest. So a critically ill child does not refer to any particular disease. So we should not be at the initial few hours, we should not focus on any disease. So our focus should be on this physiological impairment and classifying the child. Because almost all the conditions, all diseases ultimately lead to this. So this is where we need to act, and subsequently once we are stabilized, then we can move on to the identification of the etiology. What are the survival rates between a respiratory arrest and a cardiopulmonary arrest? So if we see the respiratory arrest has a better outcome than the cardiopulmonary arrest. Then we come to what are the important points in a sick child, because children are difficult to assess. The signs may be subtle or may be masked or may be overlapping. And the child may appear more unwell, maybe more unwell than what they appear, because they may be, like I said, the signs and symptoms may be masked because of these compensatory measures which are happening inside the body due to various physiological mechanisms. And these waxing and waning fluctuations can occur between a normal to an abnormal state in the child. And most important is they can rapidly deteriorate. They worsen very fast. They don't give you time. And these signs and symptoms of illness may not be readily expressed as they are in adults. Adults manifest it much more significantly than in children. And we need to assess them continuously and over a period of time. Maybe single event or single assessment may not be enough. And repeated observation are needed to detect the subtle signs or clues. And presenting complaints may be same, but it is the recognition and assessment which will make the difference. So any child may present with tachycardia or tachypnea or feeling listless, or maybe saying he is not behaving properly as before, or he is not eating well, or he has been crying since last night. So they are very subtle or very vague symptoms. So various conditions can cause that, but it is our own approach to that which will make all the difference. So what do we do in an emergency or as a physician when this child comes? We have to take the history. We have to establish a diagnosis. We have to do certain procedures and investigation. And if the child is sick, we might have to resuscitate if he's crashing and then stabilize, put him on monitor, arrange various consultation, and if needed, transfer to PICU or to the ward. So all this has to go in sequence or side by side. So this sequence has to be right for every child. So when the child comes to you, we have to see the life-threatening problems where this is appearance, airway, breathing, and circulation. If we do these 3-4 things right in the initial 1 or 2 minutes, that can take a lot of pain away from us. Then based on that, we classify them into a physiological status, do a triage, manage and stabilize the ABCs, monitor the child, take then subsequently a detailed history to establish the etiology, get the labs and arrange consultation. So usually in any busy emergency, there could be number of patients, there could be huge rush, or in any given time, suddenly you get 4 or 5 patients who are sick or maybe relatively stable. So the workload subsequently increases. So here is what is important is this triaging, and this classification becomes important to tell you that which child needs to attend first. So approaching a sick child in emergency room is different than approaching a sick child in the OPD. So here we need to have a rapid assessment. We have to identify the physiological impairments. We are not here to make the differential diagnosis in the first 1 or 2 hours. Here we are to identify these physiological parameters and then start the timely stabilization, supportive care, and the treatment. So for this, what do we need? We need to evaluate, identify, and intervene. So these 3 things, as per PALS and as per the triage approach and as per ETATS by WHO, all highlight that evaluate, identify, and intervene. So what do we mean by evaluation? Initial impression, primary assessment, secondary assessment, and then diagnostic test. This will cover most of the things in the stabilization and recognition. Then you identify the type and severity, and based on that, you intervene. At any point in this circle of life, if there are life-threatening problems, you immediately, then you don't go follow this, you start the life-saving intervention. That could be cardiac arrest, CPR, or whatever. So based on this, then as we have highlighted, it's the triage which is very important. So what is triage? It is a process of assessing a patient in an emergency room to define urgency of care and prioritize your management. Triage in the ER in the West is done by nursing staff supervised by doctors, but I think here in India, most of the hospitals are done, the triage is done by the physician themselves or by the residents and fellows. So triage has come from a French word which means sorting. So that is what we are doing. We are in this pack of cards, we want to sort out all the patients based on their severity. And most important, triage is not first come, first serve. So that will totally spoil the purpose. It's an opposite to OPD where it is first come, first serve. Here it is based on the severity. So they are attended first and the least important or the most stable patient are attended last. So what do you do in triage? You critically look for life-threatening problem. Then you determine the severity of physiological derangement. You triage into categories, various categories. Then decide appropriate treatment. And then you assign your resources. You want to use your nurses, resident, and your beds and other infrastructure in the hospital accordingly. Like if you have only one bed available in the PICU, so you will obviously triage and see which is more salvageable or more critical or who needs it. So you'll shift that patient rather than the other two who are then kept waiting. So what is step one? So this is a paired triangle. So which includes the appearance, breathing, and color. So this is as the child walks into your emergency. So this is the first look. So in this, you identify the life-threatening condition that will require immediate intervention. So in this, you classify your patient into life-threatening versus non-life-threatening. Like appearance, he is pale looking, blue, normal color, how is it? Breathing is, or he is listless. Similarly, breathing, whether he is breathing or not, and any sounds which you can hear, and then the color of the child. So these three things, you don't touch, you just only see and visual impression. What do you come out of this patient? So it can be drowsy and lethargic as an appearance, fast breathing, and child could be looking pale. So these just will tell you that this child is critical and will need immediate attention. So we will need to attend to him fast. So based on this appearance, breathing, and circulation, if all three are normal, you will classify this as stable and you will not intervene. And that will go into the green category. If you have an abnormal breathing, like he is breathing fast, tachypnic, then you will call it as respiratory distress. So you can start oxygen in a non-threatening manner and then you can reassess again. If his circulation is abnormal, then it falls into compensated shock. You can start oxygen, establish IV access, connect to cardiac monitor and check the blood glucose level. Now, if your appearance and breathing are abnormal when the child comes, that goes into respiratory failure because now you are having a breathing problem also, and that is affecting his mentation. So he's becoming listless. So his respiratory compensatory mechanism, that means, has failed. So you'll stabilize the airway, start 100% oxygen. You might even need to give bag and mask ventilation if required. And his appearance and circulation are abnormal. That means his compensatory mechanism for cardiac compensation has failed. So he's in hypotensive shock. Again, start 100% oxygen, get an IV or IU access, connect to cardiac monitor and check the glucose levels. If his only appearance is abnormal, that means his brain is probably affected. So he falls into brain dysfunction or systemic dysfunction. Then you establish IV access, oxygen, connect monitor, check glucose. And if all three are abnormal, that is a imminent or a cardiac respiratory failure. That's a very significant step. So you need to start CPR if heart rate is less than 60 despite adequate ventilation or absent cardiac pulses. So you can realize that just with these three important things of appearance, breathing, and circulation, how anybody as a pediatrician can classify the child into various states and then start managing this patient. Subsequently, we move into the step 2. After the paired triangle, we move to the pentagon. So pentagon is consisting of 5 components. That's the airway, breathing, circulation, disability, and exposure. So this paired triangle will take hardly few seconds. Pentagon can take approximately a minute to 2, which you can then, after initial intervention following paired, then you can move on to the pentagon triangle. So this will again classify the child based on physiological abnormality and sort them out based on severity. So 5 parameters should include everything from A, B, C, D, E, and E should be head to foot examination and after exposing the child. Additionally, you can add a pulse oximeter here. You can check the blood glucose. You can get the monitor ECG as a part of the primary assessment. So this is also included in that. And I think most of the units or any hospital or emergency would be having, even in the peripheral health center would be having these three things available with them. So what do we look in the airway? Airway is any abnormal airway would lead to increased inspiratory efforts with retractions. There could be stridor and there could be absent breath sounds despite the respiratory efforts. So all these classify as abnormal. So based on this, you can classify your airway as a clear and maintainable, that the child can maintain it so it doesn't have a risk of aspiration, or not maintainable, that he is comatose or drowsy, so he has a risk of aspiration. So then you need to put endotracheal tube or other airway mechanisms have to be put in place. So in breathing, what do we look in breathing? We look at respiratory rate, whether it is increased, decreased, irregular, or quiet breathing. Then the work of breathing is increased or not based on the retractions, grunt, stridor, and wheeze is present or absent. What is the air entry? That will give you a rough idea about the tidal volume and the adequacy of ventilation, which is important. Chest rise is there or not, whether it is asymmetrical or not, again will give you a lot of clues into the etiology of the disease. Then what kind of lung sounds after auscultation you can hear, Krebs, wheeze, or stridor. Then you look at the skin color and temperature, which can be which can be abnormal because of hypoxemia, like the skin is cold, clammy, cyanosed, or pale. And then you check the pulse oximetry following this. So these 6 things in breathing you have to note or record. And based on that, once you have done, you can classify as upper airway obstruction, lower airway obstruction, a parenchymal disease, that's a lung tissue, or there is a disordered control of breathing, that means the CNS is a problem and that's why the respiratory issues are happening, or there is a acidosis leading on to tachypnea. So this is your source where the problem lies, and the severity can be classified into respiratory distress, and when the compensatory mechanism fail and it goes into respiratory failure. So these 5 localizations of the disease in respiratory after airway and breathing can lead to your subsequent steps. Subsequently, you moved into circulation. You check the heart rate, what is the rhythm. You check the pulses, both proximal and distal pulses need to be checked. Cap refilling time, skin color and temperature, and blood pressure and the pulse pressure. Along with it, you check the perfusion, that is the quality of pulses. Skin perfusion based on the cap filling time we have already discussed. Vital organ perfusion of the brain and the kidneys is important. All these things will give you information of these important parameters. So all patients presenting with compensated, decompensated, or cardiopulmonary failure should be immediately connected to a cardiac monitor to recognize the rhythm, because that is what your clinical examination will not tell you what kind of rhythm is it. So we need to have a continuous cardiac monitoring going on in these patients when they present to you. So they can have a compensated shock. That means the blood pressure is maintained, but he is having other abnormal circulatory parameters. Decompensated shock is when the blood pressure is lost, that is, it is below the 5th centile for the age. And cardiopulmonary failure is when they have gone into cardiorespiratory decompensation or arrest. So once you attach to the monitor, you can get various kind of ECGs. So you interpret those and decide whether it is any problem is there or not in that ECG. So now after this circulatory examination and putting him on cardiac monitor, you decide whether it is a hypovolemic shock, it's a distributive shock, it's a cardiogenic shock, or the obstructive shock. So these are the type of or etiology-based shock, and then the severity is classified as compensated shock or a decompensated shock. Like I said, compensated is when the blood pressure is above the 5th centile and the body is able to maintain the map by the compensatory mechanism, but the child is still in shock. So normal blood pressure does not mean that there is no shock. And decompensation is when these compensatory mechanisms fail, the blood map falls below the 5th centile and child goes into decompensation. Then you move to the D component, that's a disability. So here you use your F2 scale or the GCS scale. So F2 is air alert, verbal pain, and this alertness, it will give you all that parameter. It's very easy to use, and GCS is the Glasgow Coma scale. See whether child is having eye contact or not, but whether his speech or cry is okay, What is his motor activity? Any seizures are present or not? Whether the child is posturing or a normal posture is there? What is his muscle tone and what are the pupillary sizes? And you also estimate the blood glucose at this stage, and then you decide whether there is a cortical dysfunction or a brainstem dysfunction based on that. So now based on this, you classify it neurologically, whether it is stable, cortical or brainstem problem. So with this, you will come to know whether it's a primary brain dysfunction. That means the brain parenchyma is affected, whether it is meningitis or encephalitis or stroke or bleed or anything, or it's a systemic dysfunction like a enteric fever or a scrub leading on into a global encephalopathy. So leading to secondary brain dysfunction, that is shock, respiratory failure, etc., can also cause global encephalopathy. So that is systemic dysfunction. Then we move to the E component, that is the exposure. What is the temperature? Normal, euthermic, hypothermic, or hypothermia is there. Any injury marks are there, rash, odor, or any skin bleeds. Again, give you a very vital information. Any desquamation or any ulcers are present. And the color of the child, cyanotic, ectric, pale. So all these have to be seen and documented properly. So you need to do a detailed head-to-toe examination in this case. So now once we have identified the respiratory, circulatory and neurological, based on that the severity could be either respiratory distress or failure. It could be either compensated or a decompensated shock. It could be a cortical dysfunction or cortical and brainstem dysfunction. So respiratory types could be upper airway obstruction, lower airway obstruction, parenchymal disease like pneumonias, disordered control of breathing could be there. Circulatory falls into hypovolemic, distributic, cardiogenic, and obstructive, though there may be an overlap. One may not be able to exactly classify that this is definitely cardiogenic or distributive. So there could be slight overlaps also because this is a body physiological mechanism. And then primary or secondary brain disease. All these things, if they club together, come into cardiopulmonary failure and then can lead to cardiac arrest. So these cardiopulmonary failure and cardiac arrest is the stage which we want to avoid. We want to act it here in the early stage. So based on that, once we have classified, now we do our triage classification, that where do we want to label this child as, whether it is level 1 or level 5, which varies from resuscitation, emergent, urgent, less urgent or non-urgent. So that is very important. So appropriate stabilization based on that becomes the step 4. So you identify and manage the life-threatening problems, then go to stepwise to stabilize your airway, breathing and circulation and all. So what are the life-threatening management conditions where you could take certain life-saving measures? So if there is a complete or severe airway obstruction, you need to intervene fast. If the child is apneic, significant work of breathing is there or bradypnea is there. In circulatory, no pulse is present, poor perfusion, hypotension or bradycardia is there. An unresponsive child or decreased sensorium, and hypothermic, bleeding, petechiae, purpura or abdominal distension are there. So these parameters are need to attended immediately and they fall into level 1 category. So for airway, what do? We need to position the child, suction, do a jaw lift, jaw thrust if needed. Oropharyngeal and nasopharyngeal airway need to be placed. You decide whether he needs endotracheal intubation or not. And in severe upper airway obstruction, to think of tracheostomy or cricothyrotomy or LMA device need to be used there or not. So initially you can start supplemental oxygen, see whether efforts are present and desired FiO2 has been on the desired FiO2, good SpO2 has been achieved or not. So basically they need an increased alveolar oxygen demand and it leads to increased PaO2 gradient and it can also lead to improve in the oxygenation. So if efforts are there, then you can deliver the oxygen by a non-threatening manner. If there are no efforts, then you need to give the assisted ventilation. Coming to circulation, one is to realize that optimization of preload becomes the first step in therapy for shock, irrespective of the etiology, whether it is cardiac, distributive, hypovolemic, whatever. You have to optimize the preload. The volume may differ, but you have to think about it as the first step in the management of circulation. So when give a fluid resuscitation, and then once the heart rate decreases, you have improved perfusion parameters or blood pressure improve, mental status improve, urine output improves, your lactate or mixed venous oxygen and other surrogates. So these are some of the surrogate markers or the clinical markers which can tell you that your fluid therapy is working and now you need to stop that. And here comes the role of inotropes or vasopressors. So you need to start inotrope like dopa, dobuta, or adrenaline to increase the cardiac contractility. Vasopressors are noradrenaline or dopamine to increase the vascular resistance and the blood pressure. Vasodilators are sodium nitroprusside, which can decrease your peripheral vascular resistance and the afterload. And inodilators will decrease the afterload, but will also improve your cardiac contractility like milrinone and amrinone. So these drugs are very handy and can be used appropriately based on the condition of the child. And these are to be started once your preload has been optimized. So they should not be your first line drug. The first is the fluid resuscitation, and then these come into the picture. How do you manage disability? So you need, most important is to protect the airway and breathing, because these children usually have poor airway protection reflexes, risk of aspiration is there, or they have abnormal breathing or no breathing. And second is to look for any seizures. Most of these children with CNS problems can come crashing to your emergency or your practice with status or continuous seizures. And also to control the intracranial pressure. So you provide the basic first tier care, which could be head and elevation, appropriate sedation, maintain good perfusion, maintain normal temperature, because hypothermia can also worsen ICP, maintain oxygenation and normocarbia in these conditions. And along with it, you correct your metabolic parameters like glucose, sodium, potassium, calcium, magnesium, and acidosis. So these are few electrolytes and metabolic levels which you can check when you doing your Pentagon assessment and sending your labs. When do you transfer the child to the ICU? If there is significant airway compromise, shock or respiratory distress or depression is there, child is going into refractory status epilepticus, there is significant fluid and electrolyte abnormality or other metabolic derangements is there, and child is going into multiple organ dysfunction. So these are the conditions when you need to, after initial stabilization or management, you need to shift the child to ICU for subsequent care. Ongoing reassessment becomes an important part once you have seen the child. So reassess after each intervention, whether after oxygen, is the saturation better, is the breathing better, after each bolus, how is my pulses, how is my heart rate, how is his other perfusion parameters. So these all becomes important. So you have to follow these evaluate, intervene, and assess and intervene parameter. Evaluate, identify, and intervene. So this EII has to be followed properly after each intervention to see that whether that intervention is working or not. So this ongoing assessment, also many people have used pediatric early warning scores to decide whether your child is improving and not improving, and which child will go into collapse or worsen. So it's a bedside scoring system. Basic parameter, vital signs, and behavior tools are there, which can tell you whether which child needs more care and versus the other. So it tracks the deterioration. But triage, this is different from the triage which we have discussed earlier. Triage is for the initial part. Subsequently, you use this PU score or other hemodynamic parameter scores. So it can be used both in ER, also in the ward if you need to transfer to the child to PICU. So there are both digital and automated PU system are there now in the Western countries, which can enhance the sensitivity in busy units. So like a 6-year-old child was with dengue, you have done the triage, you have initially stabilized the child. Now, after 6 hours or 8 hours, you see that the PU score has risen from 3 to 6 because he has developed tachycardia, has developed prolonged CRT, has become irritable. So that should now trigger your escalation. Your fellow should try to call you and see that what need to be done. You assess again, you decide whether fluids are needed, any inotropes are needed, or what intervention, why this score has increased. And you have to act it before the child goes into cardiac arrest. So this is where the PU score on the ongoing monitoring becomes important to prevent crash of the child. There are various scores available in the Western world, and they have used it with great success in identifying the severity of these children. So we in our emergency evaluated these 5 scores, which are very commonly used in the European or the American or Western countries or high income countries. The CHEW score, the Brighton score, the Cardiff and Wales score, Birmingham and Toronto score, and the BPUs. So we used it in a malnourished children who presented to emergency, because that is the big chunk of the children which comes to emergency, and we wanted to see that whether these score have good sensitivity or specificity. So we found that only the CHEWs and the Brighton have the very good area under the curve, more than 0.8, and they could correlate with the in the outcome in malnourished children. But even though they have good area under the curve, their specificity or sensitivity was low, and their positive predictive value was also low in that case. So ideally, none of the score performed excellently, but if you have to use the CHEWs and the Brighton are the one which is good. So what does that mean? That means we need to develop our own scores to tell us which is a good or a better score in malnourished children or in low and middle income countries, which can tell you your ongoing mortality or not. We also compared our score with various other scores which have been used in for PICU transfer or to identify deterioration or to identify cardiopulmonary arrest. So again, means only the CHEWs and Brighton did well in the comparison when compared to the other scores and in other kind of setups. So in our emergency, we have identified the triage form. So we have also built up the triage form for primary health center, for the secondary health center, and for tertiary health center. So this is based on the facilities available. So we have been training our peripheral health care doctors in Punjab, Haryana, Madhya Pradesh, and other district hospitals. And we are based on the facilities they have. So this is the triage form which we have developed for a primary health center, in which we ask them to use this PAT triangle. And then this airway, breathing, circulation, disability, and is very basic. We are not asking them to do anything big. We just on the PAT, they classified the child into stable and unstable. In airway, they need to see open obstructor stridor is present or not. They identify the respiratory rate, efforts, auscultation, and cyanosis. Then in circulation, they look at cap refill time, temperatures, what are the central pulses, peripheral pulses, and malnourished, they are severely malnourished or not. Then what are this APU score? We don't ask them to use the GCS. What is the motor activity and what is the blood glucose it's available, and dehydration level. Based on that, any priority signs, and they classify into stable, respiratory distress, failure, and all that, and emergency, priority, or less urgent. So this is a very basic triage form for a primary health center, which can be used in very minimal facility, and within few minutes anybody can do it. So this is a slightly high up for a district level hospital, which we have designed. Again, PAT is the same. This is almost the same with not much difference, with slightly more. Maybe we have added SpO2 here in this, so they can measure the saturation also. And then rest of the parameters are almost the same in that. Then this is the tertiary care which we follow in our own emergency and can be followed in very equipped emergencies. So this can be followed, which is a more detailed triage form. So you have a more detailed airway, breathing, circulation, disability, and exposure. And your classification still remains the same, whether it is resuscitation, emergent, urgent, less urgent, or non-urgent. So this is how we fill it. These forms are filled when any patient come to our emergency. And then we also have these color-coded charts, which we slips, which we give them. We classify them into level 1 and 2, level 3, or level 4 and 5. We hand these chits to the patient when we have filled this triage form. So they become very patient and very calm. So they don't trouble you. They know that somebody has seen, and my child is not critically ill. If we hand them over them the green slip, so they can wait. They don't trouble us. We tell them that your waiting time is more than 1 hour. So they are more relaxed. So this will help you in classification and also preventing a lot of medical legal problems in this. So with this, I would like to say that triage classify patients based on severity of illness and urgency of care, and required for the sickest get stabilized first. Initial rapid assessment using paired triangle helps to identify life-threatening illnesses and injuries. Subsequently, ABCD approach can help identify any physiological derangement. I would again stress any physiological derangement can be assessed through this. And life-threatening problems identified at any step. If you get cardiac arrest or cardiopulmonary arrest, then you don't follow this loop. Then you have to go directly into CPR. So such a structured approach saves time and improves care in the emergency. So thank you so much.
Thank you, sir. I would request Dr. Veena to please take over the proceedings from here.
Thank you so much, Arun sir, for that wonderful presentation. You covered all of the aspects in a very simple and easy manner for everyone to understand. Let me just share the screen. So we took a lot of opinion polls in the group for the delegates, and so this was one of the questions we asked, which is not a component of the first hour sepsis bundle. Obtaining blood cultures, giving 20% albumin, measuring lactate, vasoactive agent, and IV antibiotics. So these were the opinions of the delegates. So most of them gave fluids, started antibiotic, and also took blood cultures. But takers for vasoactive agent and 20% albumin were very less. So your comments on this, are they important? Should they be done within the first hour or not?
Who are you asking, Veena?
Ma'am,
Anybody, ma'am, you can take it up.
ma'am, you can take the question first. Yeah, I
Yeah.
wasn't
Also answer.
So one of the things I think all of us have learned over the years is that we give a lot of fluid in the first hour, but we forget that there is something going on in the vasculature, even at the capillary level. And you need to help that vasculature to support your fluids. So instituting a vasoactive agent very early in the game, even sometimes after your first bolus, is actually very important, because together the fluids and the vasoactive agent act and improve your perfusion and your blood pressure. Blood pressure comes secondary to perfusion. Perfusion is paramount. And it's very clear in our guideline that we need to give the vasoactive agent through a peripheral line. Do not waste time in getting a central line. That agent is to be started, whichever you choose, in the correct dilution through a peripheral line. So vasoactive agent is important. Albumin takes a back seat. Everyone is right in not putting albumin. That's not important in the first half.
Absolutely, ma'am. So I think probably the reluctance is because they don't have a peripheral line, so people are not confident of starting vasoactive agents.
Can even be given through an intraosseous.
Right now. So visual aids in our ER and PICU help us because we have a lot of algorithms, we have a lot of calculations in pediatric, which we sometimes tend to forget in a acute scenario. So, for example, if we had this one on of the surviving sepsis, which is reminding us of all of the steps, then probably we would be more proactive in management. So, ma'am, there are various visual aids like for cardiac arrest, for example, and GCS scale. So, what are the important visual aids that every pediatrician should have?
So unfortunately, these visual aids have been up in our ER for the last several years. They don't really change much. I'm not sure how many people actually look at them when a person comes in. But that particular one of the sepsis, I notice that it is put in, we have a triage bed. So red goes into one area, and this is put into the red area. And I have noticed that especially the antibiotic, the nurse sometimes prompts, Doctor, antibiotic nahi diya. So I think it's a visual aid for everybody, not just the doctors, because you can't be looking at something and doing something, but the whole team has to be cognizant of these visual aids and keep looking and seeing if we've missed anything. So this is something that actually the Surviving Sepsis guidelines have, the campaign has put up in all ERs. And similarly, just a reference, who can remember Glasgow Coma Scale? This is 4 and this is 3. A quick reference, just look at the board and you can easily measure it. So these small things do help. You saw a long one on the PALS, the entire PALS is written on that. Again, just a guideline, something that if you've forgotten, you think you want to look up, you can easily look that up. And the CPR one we keep everywhere, in every single ward. But at least if the basics are done correctly, then the advanced part can be taken over by the team that comes. So these are the visual aids I use in my hospital. I just hope people are actually looking at them.
Yes, ma'am, absolutely. Especially the CPR one is definitely needed in any inpatient or even outpatient scenario. So this was another poll we took, fluid resuscitation. It is best given by central line, PICC line, intraosseous, wide bore peripheral cannula, and narrow bore peripheral cannula. So most of our delegates went in for the wide bore peripheral cannula and some chose intraosseous. So why, they are right, ma'am, but why not a PICC line, for example, to give a fluid bolus?
The principle of physics actually comes in here. Short, wide, even if you have a tap that's giving water, if you have a narrow nozzle, you're going to get a trickle. If you have a wide nozzle and a short tap, you're going to get a flow. That's the principle. The reason I actually put this in is continuously, even in my ICU, I find that when a fluid bolus needs to be given, they are fiddling with the central line and the nurse is trying to fiddle with the central line and put the fluid bolus on when there is a nice 16 gauge IV cannula in a peripheral vein. So wide bore peripheral cannula, nothing more fancy. PICC line is a very long line. It has to be treated with extreme respect. It has to be treated like a central line with proper gloving and everything. And it's a very long, very thin line. It has a different use altogether. And the other thing that people, when there is a port in a onco patient, people are very keen on using the port because it is easy access. It is not the correct way to go. Short, broad, wide cannula is the best.
Absolutely, ma'am. Central line, especially fiddling with it, and it wastes time too, and especially
and causes infection because you're in a hurry at that point.
Absolutely. Point well taken. This next question is on the fluid bolus in hypovolemic hypotensive shock in a patient with acute gastroenteritis. So the options were first with regard to the volume. So it was 20 ml per kg over 5 to 10 minutes. Many chose this. That this is right. Between normal saline versus RL, RL was preferred by more. And in severe acute malnutrition, people said the preferred fluid is RL plus 5% dextrose. So this also had a lot of takers. Ma'am, your comments, and sir too.
We just stick to normal saline. Because
that
rather than give options to people, probably you can use all of these. The only thing is the last one, RL with D5. D5, if you're giving as a large amount, you may cause problems. So unless the child is known to be hypoglycemic, I'm not sure that D5 is really indicated. And it may be indicated initially, but after that, if you need to give multiple boluses, then we avoid D5 because you just get a spurious hypoglycemia. I don't know what Arun's take is on this.
No, I agree with my initial. I think we all leave it to normal saline and try to resuscitate, and that could be the first fluid of choice, and then the second becomes a ringer lactate if wants to. But I think we should stick to normal saline if one has to choose one fluid.
But
the advantage of ringer lactate
don't
is
forget to check the dextrose.
Yes,
especially in the SAMs.
The advantage with RL is that you can correct your acidosis slightly better as compared to saline. Otherwise, I would go with the isotonic fluid, normal saline.
So normal saline, first choice in any blanket situation. RL is helpful in cases of acidosis. but we can just give normal saline as the first bolus without thinking much. For dextrose, we need to check the sugars and correct it separately rather than use a large volume dextrose as a fluid bolus. This is a very interesting question. Definition of hypotensive shock in children. So we asked if the systolic pressure is used, mean arterial pressure is used to define, or is just the presence of thready pulses, delayed CFT, and altered sensorium enough to call it hypotensive shock? And is a systolic pressure of less than 70 in infants hypotensive shock? So all of these had good amount of takers. Ma'am, your comments on this? So do we need BP to define hypotensive shock? And which should be used, systolic or mean arterial pressure?
Unfortunately, hypotensive shock is still defined by BP. And recently, they have switched the systolic BP to mean arterial pressure, even in the SOFA score. But here, I would absolutely want to put an important caveat that blood pressure does not define shock. It is extremely important, poor pulse, delayed CFT, because when we don't look at these signs and we progress to hypotensive shock, we actually will lose our patient. Recently, we had a boy, he had good BP, but continuously for almost 72 hours, he had no pulses. He absolutely had no pulses. Now, this is a child, I would not say he's not in hypotensive shock. He would have definitely been in hypotensive shock. We were getting a spurious BP because of the severe vasoconstriction that was probably occurring in him due to catecholamine, plus what we were giving him. So while, yes, mean arterial pressure is used to define hypotensive shock, it is not the only thing. Please look at the clinical picture first. And one of the things I was going to say also is that instead of staring at the monitors, check the patient. Multiple times, keep checking the patient. Stare at the patient, not the monitor.
Yes, ma'am. Yes, we do tend to get a little lost if we start looking at the monitor without taking the clinical context. So these are the guidelines for defining hypotension as per pulse, which is on the right side. And this is what we generally use for all types of shock. And the Surviving Sepsis campaign also gives some cutoffs, which are slightly different, but this is particularly only for septic shock, whereas the one on the right is for the more broader types of shock. So would you agree, ma'am? When should we be using which cutoffs?
I'm not sure. We generally use the one in the PICU, the one on the right. Although I do tend to say that less is more, less is more. No one's going to die because their BP may be a little lower than. So again, look at the entire picture and not just numbers. Here you can get lost in numbers. BP goes from 70 to 67 and someone will increase the ionotropes. So that's also very, very important. Numbers, I would stress, are a guideline. They do not tell you the whole picture. They're just to help us. Arun, anything you need to add to that?
No, I think we also, on the PICU formula for calculating MAP or the systolic blood pressure is what we do. And that is what is widely followed. On the left, what is there is basically for those at the peripheral health centers where we need to just tell them the simple number that follow this number and you can do it. But if you have the facilities, I think we would follow the exact formulas and try to measure it based on these formulas. And that's what mostly tertiary care centers do.
Dhiren sir, any comments? Right, sir. So while measuring BP, it is important for us to have the appropriate size cuff too. So the bladder should cover 40% of the mid-arm circumference and the length should be 50 to 75% of the upper arm. If we use a wrong size cuff, then our BP readings are wrong. And then if we start chasing these BP readings without looking at the other signs of shock, then probably we would be too aggressive in our treatment. So looking at the pulses, looking at CFT, these all matter as much as the blood pressure does. And just as ma'am said, that chasing the blood pressure too much is probably, we are more getting into less is more scenario where lower cutoffs we would accept.
One other thing is that cuff BP is notoriously inaccurate in shock. Unfortunately, without a PICU, without the ability to put in an outline and monitor, it does become difficult, but it can be notoriously wrong, in especially at the lower values.
Yes, because the perfusion, if it is compromised, it becomes very difficult to measure the blood pressure at that stage in non-invasive way.
Yes, point well taken. NIBP may be false in the case of severe shock. Next, coming on to the definition of hypoglycemia in critically ill children, excluding neonates. So what is the cutoff? Is it less than 60, less than 40? And how do we treat it? So most chose giving 5 ml per kg, 10% dextrose bolus. Nobody gave a 25% dextrose bolus via peripheral line. So ma'am, are they right, or can we give 25% dextrose via the peripheral line?
You don't need to give, because if it's hypoglycemia, giving the correct amount of D10 through a peripheral line will correct your immediate problem. You don't really need to give it. Sometimes you're stuck in a situation where you have to give a high GDR for a long time. And while you're getting the central line, you may give D25. But usually it is not necessary. When you want to correct the immediate hypoglycemia, your bolus will help you, and then you can start a drip while you're putting in, if your GIR or GDR, whatever you want to call it, is low and you need to bump it up.
Absolutely, ma'am. Sir, so can we use 25% dextrose as a bolus in a peripheral line? Or do we need to put a central line for giving 25% dextrose? As ma'am said, for a GDR, when we escalate, then we probably would need central access for higher GDRs. But what about for a just simple bolus?
Yeah, see, 25% dextrose is highly hyperosmolar. So giving it through peripheral line can cause its own problems. It can cause extravasation thrombophlebitis and can lead to. The purpose is to give exact amount of dextrose. So if that can be given with a lesser strength of 10% dextrose with a slightly higher volume, it's to correct the sugar levels in the body. So that should be good enough, because 5 ml per kg, 10% dextrose as a push can be easily raise up your blood glucose level as fast as 2 ml per kg with 25% dextrose. But the risk with that through peripheral line is more.
Right, sir. And the cutoff is less than 60?
Yes.
Don't go for lower cutoffs, they will land you in trouble, because anyway, at that level, the dextrose sticks are not very accurate.
Yes, ma'am.
As the lower you go, the less accurate they become. So 40 is a little dangerous.
It's a little too low. So
Yeah.
less 60 we should treat. Right, ma'am. Going on to the next question, definition of respiratory failure in children. So the options were SpO2 of more than 9, inability to maintain SpO2 of more than 92 on room air, or inability to maintain SpO2 of more than 90 on room air, or is it 94? Or is the presence of altered sensorium with respiratory distress, irrespective of saturation, also respiratory failure? No one chose SpO2 of more than 92 on low flow device with normal feeding and normal sensorium. So, ma'am, what exactly is the definition of respiratory failure?
Patient and decide. No, but see, respiratory distress means that your body is working towards keeping its oxygenation intact despite oxygen. So you're giving someone oxygen, there's distress, but your SpO2s are maintained. Failure means your body's compensation mechanisms have actually failed, and despite oxygen, you are not able to maintain oxygenation. That's, at least in my head, that's the difference between distress and failure. So I would go with the last one, that despite oxygen, you are not able to maintain your saturations. then that would be failure.
Yes, I do agree. Respiratory failure is once you're even on oxygen, body is not able to maintain this SpO2 or body is still hypoxemic. So that is respiratory failure.
Rather than going for cutoffs, the inability to maintain on oxygen with altered sensorium would probably mean respiratory failure. Coming to vasovagal versus anaphylaxis in children. So vasovagal, the clues would be bradycardia, pallor, and improving on lying down. Versus anaphylaxis would have tachycardia, flushing, rashes, and abdominal pain. So vasovagal attacks are more common than anaphylaxis after vaccination or sampling. Many chose this too. Anaphylaxis needs IV steroids and IV adrenaline, IV able before IM adrenaline. So nobody chose this. So, ma'am, your comments on
Pretty
vasovagal,
much correct.
especially post-vaccination, this is
Yeah.
a very common scenario when a patient faints. Ma'am, anything you would want to add?
Neurocardiogenic syncope is typically bradycardia, pallor, and you get better when you lie. So I think the answers are all acceptable.
Everyone is right.
Except the last one, because anaphylaxis needs adrenaline before steroids or Avil or anything else. So anaphylaxis, I would say, is definitely wrong, but the rest of them, I feel, would be fine.
Yes, ma'am.
The fainting episodes usually happen immediate. They are instant. The anaphylaxis reactions take time. It develops over a period of time. So that's very
Minutes, yeah.
classical. So vasovagal attacks, like they will just collapse. And then other thing is, if you will, let's say they recover also very fast, the faint. If you lift up their leg, you improve their circulation to the heart, they will become fine. They have no other problems in that. But anaphylaxis will proceed over a period of time unless you act on it.
So, very important clues. If the patient is getting better quickly with positioning, then it is more likely, and vasovagal is more common than anaphylactic. But we should be prepared, and IM adrenaline would be the first choice for for anaphylaxis. So treatment-wise, we asked the options of IM versus IV. Nobody chose IV. And regarding the concentration and the dose, ma'am. So 0.01 mg per kg, and the concentration, we don't need dilution. Many chose these, and they're right, ma'am.
I really can't see that. I don't know why.
Okay, ma'am. The options given were 0.01 mg per kg of IM adrenaline, which many people chose.
Yeah.
Concentration, basically, no dilution is needed for giving. We don't need to dilute it like.
You don't need to dilute. Yes.
So both of these options were right and chosen by many. So essentially, we have a pathway even for anaphylaxis where we need to first identify it. If there is a cardiac arrest, then we need to manage like any other cardiac arrest. But if not, then we give IM adrenaline, and that is the first choice before steroids or antihistaminics in this scenario. So going on to our case, ma'am, a 2-year-old girl, 12 kg, with a fever of 103 degrees, with rash, responding to verbal command, flushed appearance, pounding pulses, and a heart rate of 1 tachycardia present, tachypnea, BP 65/35. Your initial evaluation should include all of the following, which is the priority for management: dengue, fever-related signs, sepsis, encephalitis, or scrub typhus. Ma'am, if I can ask you, what should be the priority?
This may sound like a silly sort of question because it can, of course, be all of them. However, the only reason to put this in is that it doesn't matter what the cause of sepsis is. Dengue will give you sepsis, scrub typhus will give you a sepsis kind of picture. Any kind of encephalitis, ANEC can give you a sepsis kind of picture. But your management should be focused on the sepsis guidelines. That is the reason for this. That, you know, sometimes you get lost. The young person in the ER wants to prove how smart he is and give you a diagnosis. See, I diagnosed scrub typhus. That's not important. your antibiotic and your fluid management and your vasoactive management will be included, and it will cover everything in whatever situation are. Therefore, sepsis would be the way you would treat the child. Your management would go on that.
Dr. Veena, there are certain questions asked by delegates in the question answer box. We need to take them earlier.
Yeah, I think that would be good.
How to define bradycardia in neonate and children?
I think
Dr.
you can skip
Bansal,
this,
sir?
Veena. It may not be.
Okay, right.
Dr.
It's
Arun
already
Bansal?
been covered, yeah.
Okay.
Even
So,
this
and,
is a Pal's question. So
when to
this is
perform
another one I
echo-
put up in my ER, that don't forget that any of these organs be hampered when you have hypotension, when you have shock, when you have sepsis. So look at all organs, top to toe examination.
Right.
And when to perform cricothyrotomy, sir? Because intubation has already been done in our PIC.
See, if the intubation is done, then you need not do cricothyrotomy. Cricothyrotomy is before that. You have a upper airway obstruction, you can't put the tube in, it becomes life-threatening, then you do it. And if a child is intubated and now it's a prolonged intubation, you want to take, difficult to take the tube out, then you need to do tracheostomy. So that is a later stage. It does not come in the emergency.
Thank you, Dr. Bansal. Now, Dr. Veena, we are overshooting our time. We need to wrap up.
I think there were only these two questions in the chat box.
Okay.
So
certain questions were answered already by Dr. Maninder.
Can I make one or two extra points? That's nothing much, but just those caveats and signals in critical care and in the ER. Children die more of respiratory arrest than cardiac. So when you see the child, there may be bradycardia, but that's not what you need to address. It may be because of respiration. So that is very important. We have CAB, but in pediatrics, you can do ACB as well. So that's the important thing. And Arun, we talked about the Pews chart. The new Pews chart that's used in NHS now has very good, you can put your values in. So whether you have a cardiac child or whether you have a GBS, you put those exact values in because they will vary.
Yes.
Your saturations will vary, and there are red triggers, which makes it much easier for the nurses to escalate. It's a much more readable chart. So we are going to go into for the new Pews chart soon.
So I request
and one thing about temperature, people take axillary temperature in a child with shock, and you'll very often find no fever, no fever. The temperature is 98, whereas the rectal temperature is 102. So core and peripheral temperature is also very, very important, and there should be no reluctance to do a rectal temperature. Just a few silly little things that are on a day-to-day basis.
Thank you, ma'am. I request Dr. Shamina, our secretary, to please say a vote of thanks.
Before giving the conclusive remark, I would like to invite Dr. Bhandari for regarding any comments about this program. Dr. Bhandari.
Sir, please unmute. Dr. Bhandari, sir, please unmute.
Sir, would you like to give any comments regarding this program?
Dr. Bhandari, sir, please unmute.
So anyway, sir, I think he's busy in some other task. Thanks to first of all our delegates. I think their number is reflecting demand and success of today's program, because more than 150 delegates joined today's these sessions. I would like to thanks to our speaker, Professor Bansal. Definitely, sir. You said the structure approach is a key outcome of any approach to crush injured child. So definitely you are opening of the slide reflecting that is a value of the structure approach, because in the PGI your slide reflecting the mortality is less than 2% if you approach the properly systematically. So definitely after this class our student or delegates definitely get the benefit. I would like to, thanks to our chairperson, Professor Udani ma'am, give the valuable comments, and Dr. Dhiren also. And thanks to our program coordinator, Dr. Dhaliwal, made us such a wonderful program. And definitely in the subsequent classes or audience or delegates will get the more benefit. And thanks to Dr. Veena for submit the valuable discussion and move the our discussion in the right direction. I would like to thanks to our president, Dr. Pankaj, president-elect Dr. Aziz, and my treasurer, Dr. Dinesh Goyal, and my whole entire executive board members. They give the valuable inputs as well as efforts to make this program successful. And I would like to thanks to my office staff, the Sushil ji, because they're the behind of the all success and continuous smooth running of this program is doing the hard work. That is my final words to for all. Thanks to all.
Thank you all esteemed faculties, and I thank all the delegates for joining in and request all of them to please join at 9 o'clock next Sunday again. Thank you so much.
Okay.